So moving on into additional combinations. So there's data that was presented here and last year, and then updates that our group from MD Anderson reported on combinations of BTK plus BCL2. The CAPTIVATE trial was updated here at ASH, so maybe Jackie, you can give us sort of a summary on what's happening with combination therapy, combination targeted therapy, and where we think that's going.
Yes, so Nitin Jain from MD Anderson presented the longer follow-up on patients treated with ibrutinib and venetoclax, ibrutinib being used as a debulking agent, and then you add on venetoclax. And what we see with longer follow-up is that you can achieve deeper responses. And so at this moment, there are some people that are still not able to achieve an undetectable level of MRD, as he's considering modifying the protocol to extend them, to give them another year, kind of like an MRD-driven practice, to see if they can get a longer, a deeper remission, and with that, a longer remission duration once you stop both drugs. In terms of patients that have stopped this therapy, many of them are still in remission, which is something that it's very encouraging. And we see that supported by the data presented by Konstantin Tam from the CAPTIVATE follow-up from the last year when you presented the initial presentation. And currently that study is a combination with a fixed duration dosing. And the presentation also shows that patients can achieve lower TLS risk with the debulking at the time of reassessment when the venetoclax is going to be administered and initiated. Patients can achieve a deeper remission in terms of MRD depth achievement, and also there's no higher risk of toxicity other than what we would expect from single agent. So there's no new signals, and that's also very encouraging. So I think it's possible that in the future, instead of using BTK with a monoclonal antibody, we may be choosing to use BCL2 agent. But at this moment in time, the current intergroup studies are for BTK plus monoclonal antibody, obinutuzumab, plus or minus venetoclax. So we're still going to have to wait a little bit longer for an American data for that.
So combination BTK, BCL2, not standard of care,
not
being
yet.
studied in
It's
phase
only
3 trials. Are you optimistic about that strategy?
I am very optimistic from the data that has been presented.
And fixed duration, you think, is important?
So that's one of the questions that was posed during the session. Would you use an approach where you tell everyone use 15 months of combination therapy, or would you do MRD-driven? And I don't think at this moment we can answer that. I think I may agree with the presenter saying from a population perspective, it might be easier in the community to just do fixed duration regimen instead of MRD-driven because it might be too complicated.
MRD, blood, bone marrow, how do you think about those things?
From what I'm seeing, the concomitant rate is very similar. So I think, from the data from the CLL14, you can just go by the peripheral blood once, but I don't know how my colleagues feel, if you feel strongly that you have to pursue a bone marrow biopsy.
So I'll take a step back. I guess interpreting all these studies, it's really important to determine what's the most important endpoint, and is it progression-free survival, is it overall survival, is it better to give the drugs concurrently or sequentially? All those questions are yet to be answered. On the specific question of a bone marrow biopsy in the setting of a clinical trial, it seems that sequentially, if you've cleared the MRD from the peripheral blood, you could potentially do a bone marrow biopsy on those patients, which is a small number of patients who you may find a slight difference. It's less than a log or half a log difference in the levels of MRD between peripheral blood and bone marrow. It's higher with chemotherapy and less with novel agents. But I think outside of a clinical trial, I don't think for the individual patient there's any indication to monitor MRD at this stage.
I think it depends on the regimen. The concordance between peripheral blood MRD versus bone marrow MRD. For example, the venetoclax plus obinutuzumab combination, the concordance is close to 90%, which is pretty good. Whereas, for example, the ibrutinib plus venetoclax study, the peripheral blood MRD undetectable rate was almost 100% versus 68% when you're doing in the bone marrow. So there's still a big difference. So still the bone marrow MRD assessment is the golden standard in the clinical trial setting, but in the clinical practice, I think it's probably, at least the peripheral blood is a good parameter to monitor disease.